All right, this is the demonstration video for IV insertion. So I would gather all of my supplies. Obviously, I would need an order to do this as well. So I would verify my order and gather my supplies. So what I'm going to need is an IV start kit. So that looks like this. Most facilities have them. Inside is a tourniquet, some tape, usually a ChloraPrep to sanitize the area, as well as a Tegaderm that we'll use at the end, a clear transparent dressing. In lab here, we don't have these for you, but we'll have all the parts separated, so we'll show you that when you come into practice. So you need your IV start kit. You'll also need something called a J-loop or an extension tubing, and I'll show you how to set that up. You'll need saline flushes, as well as your IV catheter, alcohol wipes, gloves, and then tape's usually in the start kit as well. Again, your order from the provider will not tell you what gauge IV to put into the patient. That is up to you to decide. Remember from lecture that what we use the IV for dictates what gauge we pick. Also remember there's an inverse relationship. So the higher the number of the gauge, the actually smaller the needle. For checkoff, when you come in, you'll have an order and it might say something like patient's going to OR, they're getting a bolus of fluids. We would want you to pick a larger gauge, so like an 18 or a 20 gauge, because they're getting large volumes of fluid really fast. It might see that they're just there for maintenance fluids, so you could use a 22 gauge. Or if they were getting blood products, you would want a bigger gauge as well. The three most common gauges are 22, which is always blue. Green is always 18, and pink is 20 gauge, and we think pink is perfect. You can do almost anything through a 20 gauge. In lab, we just have the 22 gauges to practice with, but for checkoff, you would just verbalize which gauge you would select. Okay, so for this patient, they're just getting normal maintenance fluids, so I'm going to use a 22 gauge IV, so I have that ready. So I'd have my supplies, I would knock, wash my hands, introduce myself, and ask for patient identifiers. And I would let Mr. Stevens know that I'm here to put an IV in. I would ask Mr. Stevens, is there any arm that you prefer? He would tell me no, so I'm going to go ahead and use his left arm. Have you had any AV fistulas? Any history of mastectomy? Anything that would prevent me from using this arm? They tell me no. Great. I'm also looking for, scarring, bruising. I would want to avoid any of those areas as well. Also want to avoid any area of flexion. So the antecubital fossa is not a great place for an IV because every time you bend your arm, it will occlude. If I'm going to go on the hand, I would want to start lower so I don't have the catheter ending up on their wrist to occlude that area as well. So site selection is really important. So taking all of those things into consideration. We also start most distal and work our way up. That's because if we start here, there's usually a good vein right along your arm here. Like if we started here and this one blew or something happened to it, we can only go up. We can't go back down. So we always start on the hand so we have the most possible spots to work with on our way back up. Okay. So first I'm going to try to find a vein, and I'm going to be looking at Mr. Stevens' hand, again, 4 to 6 inches above my site, with the tails up, not to obstruct any sterile field. And again, I'm feeling, and I should feel a vein that's full and bouncy. Just because you can see a vein doesn't mean it's a good vein, and I need the vein to be big enough to accommodate the catheter. So if I was putting in an 18 gauge, I might want this vein to be a little bigger than if I were to put in a 22 or a 24 even. So I'm feeling, and this vein looks good. Since my supplies aren't totally ready, I'm going to take this tourniquet off and give him a break while I set up. Since we're accessing a vein, typically the patient will bleed. And because it kind of depends, if they're on a blood thinner, they might bleed more than someone who isn't. So I usually grab towels and kind of put them underneath the site just so I'm prepared. I'm going to get my supplies ready by opening up my catheter. You can see on the catheter here This is what it looks like. You pull the needle straight off like this. Again, I'm just doing this to show you the parts. This white button is the needle safety button, so when you push that, the needle will suck into the barrel. This clear spot is where you're going to see that flash of blood when you insert the needle. These little curved pieces are for holding the IV catheter when you're inserting it. You always want to hold it between your thumb and your forefinger, and you're always going towards the heart. And this blue catheter is what slips off over the needle. So when you're putting in the IV, all you're left with is this blue catheter with the blue catheter right here. There's also this little notch on the side. I don't know if you can see that. That's what we use to advance the catheter off or float it into the patient. Okay? So we never want to play with this or loosen it or anything prior. And again, you would never recap. I'm just showing you this so you know. So I have that ready. I have my Tegaderm ready. This is just that clear transparent dressing. There's always a label on here that comes off, so you would put your time, date, and initials, and that is for the dressing. So I'd have that ready to go. I'm going to have 2 pieces of tape ready to go. Some facilities might have something called a StatLock securement device. We don't have one here to show you. We will when we practice. And you might see those at your facilities to secure this blue catheter in place. Much like a Foley StatLock, we don't want it to move in and out of the vein to bring any microbes into the systemic system. For lab, we just use a piece of tape and pretend. Many facilities have different things. They used to be really popular. They're really expensive, so some facilities don't have them. So I would have that. I'd have my alcohol pads or my ChloraPrep ready, and then I have to get my extension tubing ready. So this is a sterile package. This end here is what the saline flush is going to lure lock onto, and this other end is capped. So when I open this, I only really need to worry about keeping this sterile because this has a cap on it. So I'm going to go ahead and open it in a way that I keep the package as sterile as possible. So I'm going to fold it over and just pull out my tubing, lay my package down. Again, I can touch this because it's capped. This is when I want to keep sterile. If I keep this sterile, then I can just go sterile to sterile. If I accidentally bump that, I just need to alcohol it off. So I'm going to sterilely take off my cap. Remember, you don't want to do this or that will be breaking sterility. We use all our fingers. Pull this off. I'm going to pull back a little bit, push up to get the bubble out. I can get rid of that cap. Again, sterile to sterile. And now this has air in it. We don't want to give our patient air emboli, so we're going to flush this, and it flushes with the cap on. Now that's all contained so we can touch it. Now this end is what we're going to twist onto this blue catheter. This cap is on here really tight, so we loosen it so that when we're maintaining sterility and holding the catheter into the patient, we don't have to fumble and worry about it. So I like to take it off and then sterilely just put it on half a twist. I put it back in this sterile package so I know where it is, 1. And 2, if that cap falls off, it has been kept sterile as long as I kept this package sterile. So I have my J-loop ready, I have my tape, my dressing, my catheter. I think I'm ready to go. And my gloves. So I'm going to put the tourniquet back on the patient. Wait to find that vein. This vein still feels great. In lab, we're not going to have you use ChloraPrep because we don't have them, so we're just going to have you use alcohol. So you're scrubbing and you're verbalizing that you're doing this in both directions for 30 seconds. So I did that. While that dries, that's not my sterile field, so I'm not going to turn my back on it, and I'm going to put my gloves on to allow that to dry. Then I'm going to take my IV catheter, pull that off. I'm inserting with the safety needle up, holding it between my thumb and my forefinger. Coming to the side of the vein to pull the skin taut or down. And since this catheter is this long, do you see if I started here, I would have the catheter in their wrist. So I'm going to start back here. So the tip of the catheter ends up before this area. Again, I don't want to contaminate this. So I'm pulling taut. I'm going in at a 35 to 45 degree angle. Don't get too caught up on the exact angle. Just know that you're kind of going in at a bigger angle until you see a flash. And again, this mannequin doesn't have blood in it, so it's just going to look clear. But I can see clear fluid going into the barrel, so I'm going to lower my angle to almost parallel. I'm going to push it in just a touch more, just to get the needle going in the right direction. Because the first angle was to access the vein. The second needle is to, poke was to access the vein, and then I lower the angle and go in a little bit to get it parallel with the vein, okay? So once I have it going in the right direction, I'm going to stop. I'm going to hold this hand stable with the patient, so I move with the patient. Now I have to think about sterility. I can't touch any part of this blue, any part of this needle, any part of this insertion area, and I can't touch the end of this blue hub, because we want to keep that sterile, because that's where we're putting the sterile extension tubing or J-loop on. So that's why we have this little notch, okay? You can do that one of two ways. You can hold with these fingers and advance it off like this. I personally don't like that method because I feel like I have less control and my fingers are a little bigger. So I like to hold here and use my other hand to use my thumb, and you're just kind of floating this catheter off, okay? So you're just moving the blue catheter, you're not moving any part of the needle, okay? At this point, they're going to be bleeding all over you. So you got to do a couple things. You have to hold this stationary. Again, not touching insertion site, not touching this. So I'm going to hold here. I'm going to occlude the vein above the catheter to stop the bleeding. I'm going to let go and I'm going to pull my tourniquet. Then I'm going to come back and push this safety device to let the vein come back out. And that's going to go right into my sharps. At this point, I'm still occluding because I don't want it to bleed. And I'm holding this stationary. Again, not contaminating. At this point, I'm going to take my J-loop. And this is what takes practice. I go between these fingers, and since it's so loose, it comes right off. And then I can pick it up and twist that end on. And I know it's kind of hard for you to see, but we'll show you when you come into practice. And this one's not going. Okay, there we go. Now, it's really important to keep this stable because you see how this kind of came out. On the mannequin's hard plastic, so it's going to kind of do that sometimes. And again, if it doesn't flush, we're just going to pretend. But you want to hold this stable so that this doesn't come back out. Okay? Hold stable until it's taped. Now I'm going to flush, and it's flushing beautifully. If it didn't, you're not getting graded on whether it flushes. You're just getting graded on, do you know all the steps and can you do this sterilely? Okay? So I know what it flushes, so now I can tape it. Now that this is all secure, I can kind of touch all this because this is covered. I still don't want to touch the insertion site. And again, this catheter shouldn't be out, but mannequin air. I'm taping, rewind, I should have ripped my tape in half. I'm taping over the blue catheter. In the real world, if this was a bunch of blood, I might want to clean that up first before taping, maybe take off my gloves and change them, because the tape's not going to stick. Okay? So that's secure now. Again, I'm going to flush that. And at this point, I can take off my gloves, wash my hands, asking the patient if it feels okay. This tegaderm just peels off, and I'm going to put that right over up to where the extension tubing connects. For some reason, this is it. Connected very good. Okay, so I just walk it around like that. This label is scored on the back, so you can peel that off. And I'm labeling it on the side of the tegaderm so I can still see my insertion site, because I want to monitor this area like you learned in Junior 1 for redness, phlebitis, anything like that. I usually flush it again. You have to flush with at least 3. I'm going to take that off. I'm going to lock my flush. I'm done with my tourniquet. And then I'm going to secure my extension tubing. Remember the flagging method you learned in Junior 1 as well. I'm going to flag that so that's secure. We do not have the green curio caps like you might see at clinical. So that would look like this when you're done. And then remember, you would clean up all your supplies. The needle should have gone in the sharps. You would document date, time, initials. You would document what size catheter you used, the site, how the patient tolerated it, and the number of attempts. And that is the video for IV start demonstration.